So this is a fairly simple question that is mega high yield for USMLE, and I made content on this before, all right? And it doesn't take a rocket scientist to figure out that this kid has DKA, diabetic ketoacidosis, and we've got high glucose. We've got the fruity odor of the breath here, which can be seen with the ketones. And we just want you to know the endocrine, okay? So let's just hop through the arrows here. So what are we going to expect for serum potassium? Is it going to be up or down? The answer is it's going to be up. We have hyperkalemia in DKA, and there's two main reasons USMLE wants you to know. The first is something called cellular shift, where when you're making a crap load of protons from all the keto acids, the cells are going to buffer those protons, increase positive charge, and they'll kick out some of the K plus to compensate. They'll ask that on NBME. Okay, they'll give you literally it's just the same exact simple question here. Ask you which of the following is responsible for the patient's hyperkalemia, and the answer is cellular shift. All right. The second mechanism is that what does insulin do? It pushes potassium into cells. Okay, so when insulin upregulates GLUT4, and then you get more glucose into the cell, more ATP, increased sodium potassium ATPase function. For every 1 ATP utilized, you get 3 sodium moving out of the cell, 2 potassium moving in. So if you can't do that, then you can't get potassium into the cells, so potassium will stay higher in the blood. So we have hyperkalemia. Total body potassium, it's a down arrow. Okay, so this is what's referred to as hyperkalemia despite a low total body potassium. So potassium is high in the blood, and when it gets to the kidney will sense that high potassium, and then it does what it's supposed to do, which is kaliurese. Fancy word that means to micturate potassium, kaliuresis. So you're getting rid of potassium in the urine, and meanwhile the cellular mechanisms that have potassium not able to enter the cell / being kicked out of the cell are still in place. So it's a circular mechanism where you're losing it from the kidney, can't get into the cells. So you have low intracellular potassium, low total body potassium, but it's high potassium in the blood. So then we just have our pass level acid-based stuff in terms of bicarb and CO2. So some students memorize that you have a low CO2 due to Kussmaul breathing, which is true. Okay, now we don't have to give you the respiratory rate. We say tachypnic here, deep respirations. We made it easy. Okay, so if you're blowing off your CO2, it makes sense, it's going to be low. But you got to know that CO2 is down because you have a metabolic acidosis with a low bicarbonate. And if you're metabolically acidotic, you want to blow off CO2 to compensate. DKA, of course, is the D in mud piles, the high NA metabolic acidoses. So let's look at our final answers here if I can even fucking find the arrows. So we have high potassium, low total body potassium, and then we're going to have low CO2 and low bicarb. You know if I have that combination listed here? Yeah, it's right here. There we go. High serum potassium, low total body potassium, low bicarb, low CO2. And what NBME / USMLE will do is they'll give you an easy DKA vignette on the USMLE, and they might give you 3 of these arrows. Okay, and you just have to know the basic endocrine. You know the deal. I'm going to make more content on my stuff screen channel. Appreciate your time. That's it.